I'm Margie Godfrey, and I'm here to help guide you through the Assess, Diagnose, and Treat Clinical Microsystem workbooks that you have. My colleagues and I at Dartmouth have developed these tools based on knowledge and experience working with very busy clinicians like yourself in rural, urban, large, small, and academic settings. The many tools have been tested and adapted in all of these hospital settings. Many successes have been achieved for patients and families and staff using this methodology. The DVD that you have has real-life examples of colleagues from around the country who have used this methodology and these tools, who are willing to share their experiences with you. They have intentionally aimed to improve the process and outcomes of care, and they aspire to become centers of excellence and have learned the whole organization can be no better than the individual microsystems or the building blocks of the hospital. I would like to talk with you about beginning your clinical microsystem experience. My aim is to be your guide through the two workbooks you have, Assessing, Diagnosing, and Treating Your Inpatient Unit and ED, and the Improving Your AMI, or Acute Myocardial Infarction, and Community-Acquired Pneumonia Microsystems. First, I want to point out two big differences between these books. The Inpatient and ED Microsystem Workbook is about within the clinical microsystem, the place where patients, families, and clinical teams meet. Most professionals can understand within clinical microsystems because there are usually obvious physical boundaries. You can see the ED, you can see the inpatient medical surgical unit. In this workbook, the focus is on purpose, patients, professionals, processes, and patterns within these clinical units. The second workbook is about between and across clinical microsystems. The Acute Myocardial Infarction and Community-Acquired Pneumonia workbook is focused on the patient's perspective of journey across several or many clinical microsystems or contributing units specific to their diagnosis. Many of the materials and tools in the Within workbook can be applied to each of the contributing units of the AMI or CAP microsystem. You may wish to review all the books to see what makes sense to you and what you should adapt. What is very important about the two workbooks is the Inpatient Microsystem Workbook is about assessing, diagnosing, and treating within your clinical unit. The AMI and CAP Workbook is the between and across multiple contributing units from the patient perspective. The handoffs are where errors, omissions, mistakes, rework, and gaps can occur in the care we provide. Or you could have handoffs that are transparent to the patient due to the intentional design of well-designed handoff processes. Handoffs include unit to unit, shift to shift, professional to professional. Some things that we don't usually think about, we just do it. Some examples include when the patient is transferred from the emergency department to the cardiac catheterization lab, typically an AMI patient. This is a handoff from the ED to the cath lab when you are worrying about what important information and data needs to be shared with the next contributing unit in the course of care for a patient with AMI. You need to be thinking about tests. What are the personal preferences that the patient has, and make sure that there is a smooth and informed transition of care. The coordination, communication, feed forward, and feedback systems between the sending and receiving units are crucial to be a high-performing microsystem centered on patients' care and exceptional outcomes. I'd like to give you an overview of what we're going to cover. First of all, the pre-work that needs to be done for both the within microsystem improvement work and the between microsystem improvement work. So both books require pre-work. Within the pre-work, you want to determine who the clinical leaders are who will support and sponsor this important improvement work. You need to identify who the members will be of an interdisciplinary lead team. You need to determine when there will be protected time for this group to meet and assess and diagnose and treat microsystems. You need to have a plan for communication with the rest of the members of the clinical microsystem who are not on the lead team. They need to be kept informed and up to date about the improvement activities, the ideas, the assessments, so that they can be fully on board when change occurs. And you need to also identify who will be your data and informatic contacts within your organization to help inform your process. Just like you assess, diagnose, and treat your patients, you must do an assessment, diagnosis, and treatment of your clinical microsystem, which we call the 5 Ps. We'll go deeper into that knowledge as we move forward. You need to assess your current performance data of your clinical microsystem. How are you performing? What are the outcomes you're achieving? How do they compare to best known or benchmarks? Then you can sit back and look at all of the pieces of this assessment to come up with a diagnosis. What is your diagnosis of your clinical microsystem to then guide how will you treat your clinical microsystem? And we have some great examples in the workbook and websites that you can go to find best known current ideas to implement and adapt in your local setting. The clinical microsystems already exist. You are not creating a clinical microsystem. They already exist in some highly developed situations, and some are not developed. Our plan is that you will intentionally leverage the patients, professionals, processes, and patterns to develop your clinical microsystem into a high-performing frontline unit. I want to caution you, this does not happen overnight. Microsystem development is a journey and it takes time. You decide what your timeline is. First, let's review the pre-work that I've talked about. You must identify formal leadership. You must create an interdisciplinary lead team, and you must identify data and informatic context to help support your improvement in diagnostics. You must develop a strategic communication plan. Microsystem awareness and development must be in the context of an interdisciplinary team. Identify who the formal clinical and administrative leaders are who will support and sponsor this improvement activity. Remember, leadership is at all levels of your organization, so you want to be thoughtful about senior leaders, mid-level leaders to ensure support of your improvement activities. Then create an improvement lead or core team which is composed of representation of every role within your clinical microsystem. You must also identify within your inpatient microsystem who the physician, the administrative leader, and/or nurse leader will be leading this improvement work. We've had great success and realized in our research that successful microsystem leadership does consist of a medical director, a nursing director, and/or an administrative person. You want to include doctors, nurses, clinical nurse specialists, unit clerks, technicians, assistive personnel such as nursing assistants, housekeepers, and other roles in this lead team. Remember, every member is valued in the high-performing clinical microsystem. Every voice must be heard. You have to be sure all roles are represented in this lead team. Increasingly, patients and families are invited to be part of this lead team. It's a scary thought, but there's a website from the Patient-Centered Care Group that can support your exploring this possibility. The function of the lead team, many people wonder, so what do we do in this lead team? You begin with weekly meetings to guide microsystem awareness and development and improvement. You have to have a protected day and time to meet for this hour weekly. Each member of the lead team will be responsible to serve as a bridge between the group they represent and the lead team. For example, you may have an RN who represents days and a second RN who represents nights in an inpatient unit. They must actively communicate and seek insight and feedback from their colleagues who are not in the lead team meeting. This activity will support the improvement activities and leads to getting everyone in the game of developing and diagnosing your microsystem with the opportunity when you do identify changes, they won't be surprised. This can result in a high-performing clinical microsystem with satisfied patients, staff, and exceptional outcomes. You'll meet 1 hour weekly. You'll learn to use effective meeting skills because our time is too precious to waste time. And you'll use effective meeting roles, timed agendas to keep the team productive in a short period of time. You can get a lot done in 50 to 60 minutes with organization and discipline. The third pre-work activity is to identify contact people from your informatics and data information system to inform your improvement activities. They usually are within your organization, and having senior leadership point out to them the importance of being responsive to your needs and your requests will help move your work along. The fourth pre-work activity is to develop a communication strategy for your microsystem. The lead team members need to communicate regularly and frequently in a variety of methods. Many hospital microsystems have been very creative in their communications, using a vast array of communication methods to constantly keep all staff informed and to invite participation and curiosity. Another important activity to organize, if you don't already do this, is a monthly all-staff meeting. Now, when I say all staff, it really is all staff. All the nurses, all the nursing assistants, housekeeping, physicians, everybody comes together once a month to review what is the process of care that we're improving, how are we doing, what are the measures, what are the outcomes, what will we be working on, and how can we help with the aim of becoming a high-performing microsystem. Many microsystems have been very challenged on how to accomplish this when you're providing care and services to your patients 24 hours a day, 7 days a week, 365 days a year. Some suggestions that you might build from is to hold multiple staff meetings throughout the week at the change of shifts. It could be from night to days, days to nights, and people can provide coverage for each other to assure attendance. There was one microsystem that actually held Sunday evening staff meetings with a buddy system so that people who couldn't be there would buddy up with their buddy and inform them about what was happening. And having timely agendas sent out in advance informs staff as to what the topics that will be covered and allows them the opportunity and space to provide feedback to those who will be in attendance. There's one inpatient unit that does monthly breakfasts and dinner with all staff present, so they share their reflections about improvement and progress over meals. The important thing is to remember to include all shifts, including nights and weekends, when you're planning to conduct the all-staff meetings. Everyone matters in the clinical microsystem. Another organizing and developmental effort is to hold an annual retreat of your microsystem away from the hospital. I can hear the noise now that doesn't seem possible in your very busy lives. But we have found that many organizations have been very creative in planning coverage to support clinical staff and to spend time reflecting on their current and desired processes and improvements to patient care and outcomes. The inpatient medical unit at Dartmouth-Hitchcock Medical Center were actually one unit, one microsystem that was able to, through detailed planning and clever staff arrangements, plan for a 2-day off-site retreat. Staff took turns, they brought in part-time people, per diems, even supervisors pitched in to help cover the unit while they were out on their retreat. There was intentional census control of that unit so that all staff could at some point over the 2 days participate in this meaningful retreat to reflect about the care that they were providing and to plan for the future. Even senior leaders were invited to strengthen that connection between upper management and the front line. Many of you doubt what you can do in your complex and busy setting, but remember, clinical microsystem development takes time. You need to set the rhythm and pace of your developmental journey based on your insight of your microsystem's unique characteristics. Just start with the weekly meetings, move to the monthly all-staff meetings, and eventually you'll get to an annual retreat and benefit from bringing everyone together for an opportunity to reflect on practice. Now that you have your pre-work done, let's start the journey of clinical microsystem awareness and development to achieve the high-performing microsystem characteristics you wish to have. An important point to remember at this point is the workbooks are not intended to be rapidly completed in 1 to 2 weeks. A few microsystems might have the ability to move rapidly through the assessment process, but more often, when we're trying to blend taking good care of patients and increasing awareness and development of clinical microsystems, a slower pace is more tolerable. Holding weekly meetings and strategizing how to move through the assessment at your rhythm and pace that matches your microsystem capability is very important. Generally, it takes about 2 months or even longer to complete the assessment. This process should not prevent you from engaging in immediate improvement activities, however. You should move forward with improvement while continuing to gain deeper insight and knowledge of your clinical microsystem. Take a look through the workbook. You might be overwhelmed at the first glance, but remember, this workbook is intended to guide your assessment to help you see things you might not have seen before within the context of your interdisciplinary team. Notice the sections are divided into purpose, patients, professionals, processes, and patterns. And collectively, we call these the 5 Ps of clinical microsystems. Then there's metrics that matter, the diagnosing and treating your microsystem section. The deeper knowledge you and your interdisciplinary team have for each of the 5 Ps and the metrics, the more informed you will be to design innovative processes of care to result in better balanced outcomes. One clinical microsystem manager in California reminded us of the importance of gaining this deep microsystem knowledge when she said, "I thought I knew my unit, but I really didn't until we did the microsystem assessment process. I learned new things and had new insights that led to the development of new processes and systems of cares." The workbooks are designed to help you see your clinical microsystem differently than you have before. Many professionals view their clinical microsystem from the lens of their shift or one patient at a time. We are eager for you through these tools to see the detail, but also see the processes and systems of delivering care for your population of patients. We want you to see something different to help you ask new questions and discover new opportunities to improve how you provide care and the outcomes of the care you deliver. We want you to step out of the daily work to become deeply knowledgeable and informed about your clinical microsystem. We can learn from other high-performing industries. Some industries have what they call a catwalk, to be able to step out of the process and observe from above to see what the flow and the waste and the possibilities are within their process. This workbook hopes to provide you that catwalk we don't have in healthcare. Start out with the review of the microsystem assessment of data source and data collection worksheet. The purpose of this organizing document is for your team to determine which data and information can you easily extract from your organizational systems and which data and information you need to acquire through the use of the tools and ideas in this workbook. Don't create more work for yourself if you can easily obtain these data and information from your organizational systems. Let's look at the 5 P's in the workbook. The first P is purpose. What's important about purpose is that many clinical microsystems never have taken the time within the context of an interdisciplinary team to talk about why do we exist? Why does our inpatient unit exist? Why does our emergency department exist? How can we all agree and come to agreement and consensus on why we're here? The second P is patience. This section is intended to guide you into deeper knowledge of your patient population. Many of the questions and facts have not usually been organized in a collected fashion for all staff to be aware of. You might be surprised to learn new information about your patients and even have further questions beyond what is listed here to discover. That is the point. This workbook is really about provoking conversation, observation, and reflection in your daily practice. Some of the important patient data aspects include: what is the age distribution of your patients? What is their living situation? What are your top diagnoses that you deal with regularly? Where are your patients discharged to? And by the way, what is your 30-day readmission rate? Other informative facts include: how often are your patients on other clinical microsystem units? And how often do you have patients from other units that overflow into your microsystem? And how often are you unable to admit new patients because of your census? All of these questions hope to paint the picture of your inpatient unit that the interdisciplinary members may not see. It is through seeing this data and this information that you might begin to see the possibility of designing different processes of care to better meet your patient needs. You will have deeper knowledge of your patients to inform your decisions and improvements. Another way to know your patients is through patient satisfaction surveys. If you don't have a recent survey done by your organization about patient satisfaction, you might consider using the Patient Family Satisfaction tool to gather information and feedback. You could do a sampling of patients across the days of the week and across the shifts. You could sample 10 patients a day to get a great picture, a snapshot of how your patients rate your care and services. Along with hearing patient perspectives through surveys, you could organize what we call through the eyes of your patient's experience with all staff. Staff assume the patient and family roles and experience your microsystem, maybe beginning with admission to the discharge process or any process along the way. This eye-opening experience resulted in significant changes in the noise level in one inpatient medical unit, where staff realized their conversations and daily activities really created a noisy environment they were not aware of until they participated as patients and families in the through your eyes of the patient's experience. Be sure to post all of your findings and assessments in your designated area to encourage all staff to become self-aware. The third P is know your professionals. Some of the important aspects of the professionals in your clinical microsystem include: who is in your inpatient microsystem? When are they there? What diagnostic departments support the care and services in your inpatient microsystem? What services admit to your unit? Do you use temporary staffing in the variety of forms that might require thoughtful consideration of assignments and professional needs to help them be the best they can be in your inpatient microsystem? How does staff rate working in your inpatient microsystem? Remember, you may have recent workforce surveys that can help inform your assessment. If not, you can use the Inpatient Unit Staff Satisfaction tool to help you gain insight into the staff perspective of your clinical microsystem. Also note the Personal Skills Assessment tool to help each member be the best they can be and assist leadership in developing and planning educational opportunities. Gaining deeper knowledge of the professional in your microsystem includes really understanding how professionals spend their time in your inpatient microsystem. Review the activity survey sheet to have all members list their activities to identify mismatches in professional education, license and training, and actual functions. You can start with one group like the unit clerks and then move through all the professional groups. The fourth P is know your processes. To know your processes as they really happen requires some basic knowledge of flowcharting. Review the core processes of your inpatient microsystem and with your interdisciplinary lead team, flowchart what the current known and agreed upon processes are. Remember to flowchart current known states of the processes and not what you wish or think it is. This requires observation and the involvement of those in the process. The litmus test is when you start to flowchart a process and discover you cannot draw the flowchart because the people who are involved in the process are not in the meeting. That's when you need to go back and engage their involvement. An aspect of process knowledge is measuring cycle time for core processes like admissions, discharges, diagnostic studies that support you in identifying waste and delays that might be eliminated in a new and improved process. The core and supporting processes evaluation form is a great way to get everyone in the game. When you inquire of all professionals which processes are broken and which ones patients complain about, you engage staff and ask to hear their opinion. One inpatient unit in Alaska enlarged the core and supporting process document to be wall size and asked staff to use designated colors by roles to rate each process. This was a powerful exercise when the results were visually present on the unit, and then action was taken to improve the staff agreed upon broken processes. The final P is know your patterns. What does this really mean? What are patterns within a microsystem? This is really about noticing patterns within your inpatient microsystem that you may acknowledge daily or tell stories about, but you don't reflect on regularly to understand their significance or importance. Some examples are social patterns, financial patterns, who talks with whom, what successful changes has your inpatient unit made, and what are the staff proud of. These are a few pattern examples to explore and to make public and consider carefully when engaging in improvement. The unplanned activity tracking card is a valuable tool to track the interruptions that occur when you are taking care of patients. How many times are you interrupted in the course of providing care and you just chalk it up to that's the way that we take care of patients here? Once you become more aware of these patterns and variations in interruptions, you can begin to explore improvements to processes to eliminate or reduce the interruptions. Have you reflected on the patterns of the call lights and alarms? When do they occur most? Why do they happen? Taking the time to learn the patterns and reasons may inform new designs of care delivery. Next, you want to move into review your metrics that matter. These metrics inform and guide the inpatient unit in performance. All microsystems are awash in data, but only the high-performing microsystems harness this data and create information-rich environments. Key to measurement work is to build it into your daily work. Make the measurement visible. Get it off your desk, out of your drawers, and increase visibility for all staff to see your metrics that matter over time. The data must inform you and provide valuable feedback about your microsystem performance. These metrics are changing regularly and are a result of external agencies tracking microsystem outcomes and performance. The Hospital Quality Alliance is one of such organizations helping to determine outcomes and process measures to track and ensure quality of care for patients. Review the list and also the website to ensure you are current. Step back and make your diagnosis based on the 5 Ps and the metrics on what you should focus on to improve your microsystem. What is your diagnosis? Based on your diagnosis, what theme might you choose to focus on for improvement in your microsystem? You could consider the Institute of Medicine's 6 aims to guide your thinking as to a theme. The Institute for Healthcare Improvement has themes based on access, reliability, and high-performing microsystems. The Diagnose and Treat Your Microsystem pages are intended to give you a path forward in your improvement activities. Be disciplined and stay focused by using improvement science. The field-tested tools and framework are well outlined in the workbook for you to refer to. Review the change ideas that have been tested in the field and constantly being added to based on experience with thousands of healthcare professionals around the United States. Review the IHI and the Clinical Microsystem website to find current updates and changes being tested in the field you can consider and adapt. The improvement model tested and proven through IHI and our microsystem development work is the Plan, Do, Study, Act cycle, PDSA. We have added an important phase to the improvement model called Standardize, Do, Study, Act, or SDSA. Standardization is essential in process improvement. Once you have tested a change idea, modified it, taken further action, and based on data and outcomes believe that this is the current best known process, you should move to standardizing the processes. Only when you standardize a process can you begin to move to a higher level of improvement. The last piece is to know that improvement is continuous. Follow-up is critical. Never assume that all the improvements that you have worked hard to achieve are always happening. Use data feedback and review the processes to ensure improvement is still in place. The use of data walls and storyboards help to keep the rhythm and pace of improvement. A great example happened to a colleague of ours where they had done extensive work on improving the process of surgery for bowel surgery. They had looked from the time the patient was determined to need bowel surgery until the patient went home. They implemented a pathway for bowel surgery, had standardized order sets, and 6 months later, because nobody was watching and tracking data, many of the improvements had fallen off. It's a good story to remind us that we always have to be monitoring and watching to make sure our good improvements are still in place. For those of you who are in an emergency department or ED and wondering what might be important to consider when you conduct your assessment and diagnosis of your microsystem, I want to review a few unique considerations for you. Many of the inpatient tools will work for you. You just need to think carefully about adapting them within your emergency department. You will still need to create the best conditions to engage all staff in awareness building and improvement in your microsystem. The pre-work that we discussed earlier is the same for you. To do your assessment of your 5 Ps, purpose, patients, professionals, processes, and patterns, pay particular attention to knowing your patients. Knowing the emergency department census and where variation exists in the census helps you match your resources with the unique needs of your patients. There is a helpful point-of-service patient-family satisfaction survey in the toolkit which you could use through sampling a number of patients a day on all shifts to get a sense of real-time what patients and families think about your ED. Know your professionals is similar to the inpatient unit. Be very observant during this section of the supporting departments who provide diagnostic services to your emergency department and your patients. Who are they? How often do you interact with them? And do you meet together to review processes of care and outcomes? The third P, know your processes. What is important for the emergency department is time. Timely interventions and timely flow for patients can make a critical difference in outcomes. You should make plans to evaluate the patient experience from the time they arrive until they are treated and either transferred to another unit or discharged home. The emergency department patient cycle time tool is a great tool to use to measure time and delays. You will probably need to sort the subsets of patients into urgent, emergent, and healthy sick patients to conduct your cycle time tool. You'd want to summarize the results of the cycle time into those categories. Where are the delays and wasted work and rework? Create the high-level flow chart with your interdisciplinary team for each one of those subsets of patients. It's important to build common understanding and agreement of the processes of care for these patients. Be sure to post all of your assessments in an area all staff in the emergency department can review and engage in. Review all the other tools and use them as you determine they would be most helpful in supporting your improvement efforts. The next section of ED metrics that matter should be completed and determined to discover what the gap is between your current performance and targets or benchmarks. Determine who will oversee the data collection and tracking in an ongoing manner. Just like the inpatient workbook, review all of your assessments and your metrics, create a diagnosis, determine a theme, and then move to improve your ED using the improvement model of Plan, Do, Study, Act, Standardize, Do, Study, Act. Many organizations throughout the United States have tested ideas to improve their emergency department microsystem. Some of them are listed on the Change Idea page for you to consider. You will find updated and changing ideas for your ED improvement on the IHI website. The ED microsystem case study at the back of the book is an excellent example from Geisinger Health System located in Danville, Pennsylvania, of their experience in using these tools and methods. Now let's review the Between and Across Clinical Microsystem Workbook for acute myocardial infarction and community-acquired pneumonia, or from now on AMI and CAP. Remember, we are now focusing on diagnostic groups from the patient's view of the healthcare system. Much of the Within Microsystem Workbook can be applied to the contributing units with the AMI or CAP microsystem. You will need to review with your interdisciplinary lead team what makes sense to use. My primary focus now will be the across contributing units in the AMI and CAP microsystem. During the pre-work phase, it is very important to pay attention to identifying who the contributing units are to the AMI or CAP microsystem and to recruit interdisciplinary membership from across these contributing microsystems. For example, for AMI, it would be important to identify representation from the emergency department, the catheterization lab, the coronary care unit, and the medical cardiac unit, and cardiac rehab, and even consider home health. All of these contributing units have important roles to create the overall high-performing clinical microsystem for AMI or CAP care. Protected regular meeting time is important to think about because it's a challenge to organize these individuals across the contributing units in a regular fashion. Determine a regular day, time, and place which will help to convene these individuals so that it will become a regular habit to meet. Leadership from all levels of the organization need to be sponsors and supporters of the improvement work. Who are they? Usually the physician, nursing, and administrative leadership is important at the local level, but then you need to think about vice presidents and senior leaders who could support the work across all the contributing units. The AMI CAP workbook is intended to assess and diagnose across and between contributing units within the AMI or pneumonia microsystem. Nationally, there are identified outcomes and process measures for AMI and pneumonia you should be very mindful of. Review these measures, determine your current measurement, and identify the gap between your current state and the target. Review the Hospital Quality Alliance website to stay current on desired measures to track over time. Create a data wall to track these measures over time for all staff to review and consider across all the contributing units in AMI or pneumonia care. The AMI profile provides the overview of all AMI or CAP patients in your organization. Focus on who they are, when they come to your organization, how they come, and where they go. Be very mindful of their living situations. Patient satisfaction and feedback can be obtained through your organizational survey system or by using the survey tool in the workbook. The Through the Eyes of Your Patients is a very important assessment tool to heighten awareness of the entire AMI or pneumonia microsystem and to become acutely aware of the between contributing unit processes. Pay very close attention to the times when patients are transferred to another contributing unit or transported to diagnostic areas. In the Know Your Processes section, assess all of the AMI pneumonia processes across the contributing units. What is the admission process for AMI patients, the transfer process and discharge process? How does one unit know when patients might be transferred to them? Pay very close attention to the between in the contributing units section. The handoffs of patients, information, data, and materials between contributing units is a critical time in the course of care for AMI or pneumonia care. The between handoffs is when errors, omissions, waste, rework, and gaps in care can occur. The patient is very vulnerable and at risk during these handoff periods. Evaluate the handoff process carefully. Identify when they happen, how they happen, what standardized tools and processes occur to ensure no gaps are present for patient care. Review and answer the questions about handoffs in the worksheets. Do you regularly review these handoffs when contributing units come together? Is there one way to send and receive patient information, data, and materials? Also determine if you've ever discussed within your contributing unit what you need to receive in a standardized way from transferring units to ensure complete and accurate patient care. All of the other tools in the inpatient ED workbook can be referenced and used as you see fit. But remember, the between contributing units is the biggest difference for AMI in pneumonia care. Be mindful and intentional. Once you have your diagnosis and determined your theme, you can move through the treatment section using the AMI and pneumonia microsystem change ideas based on tested ideas in the field and evidence-based improvements. Remember to review www.ihi.org to stay current with changing ideas and recommendations. Review and apply these 4 rules for handoff design improvement. If every contributing unit commits to these 4 rules, the overall AMI pneumonia process will be ideal and with limited defects and gaps. The improvement model is the same as previously discussed, except many of the improvements will occur across multiple contributing sites, and great care and attention needs to be paid to these units to support their activities in PDSA, SDSA cycles. Leadership at all levels need to be visible with support and encouragement. We have covered a great deal of material today. We have reviewed the 2 microsystem workbooks about within clinical microsystems and between microsystems. You need to decide where you will begin. Remember, the microsystem awareness and development journey doesn't happen overnight. It takes discipline, time, patience, and interdisciplinary involvement. You decide the rhythm and pace. I invite you to go to the Clinical Microsystem and IHI websites to stay up to date and to support your improvement activities. It's now up to you. I wish you great success in your journey.